very good morning to all, my dear students. I am Dr. Indira Priyadharshini, Department of Oral Pathology, Vinayaga Mission Shankaracharya Dental College. Today, I am going to talk about the topic is benign and malignant soft tissue tumor. Soft tissue tumor, it's also called the connective tissue tumor. It is arising from the connective tissue, mainly from the adipose tissues, fibrous tissues, muscle and blood vessels and peripheral cells. So either it can be from the benign and malignant. Benign tumor that are very small and slow growing lesion, it is an encapsulated lesion, it can't metastasize. But malignant lesion is the uncoordinated proliferation of cells. It has a high chances of metastasizing into the other tissue. As a dentist, we have played a vital role for diagnosing the soft tissue tumor. It's very important to familiar about this benign connective tissue and malignant connective tissue tumor. So mainly this connective tissue tumor is originating from the primitive mesenchymal cells. The classification, it is according to the differential lines. So the classification of soft tissue tumor, fibrous tumor, it is a benign fibrous tumor, it's oral fibroma, giant cell fibroma, peripheral ossifying fibroma or peripheral giant cell granuloma. Okay, so the nerve tissue tumor, either it can be arising from the nerve tissue, it is neurofibroma, schwannoma or malignant schwannoma, that is the malignant counterpart of the nerve tissue tumor. Lipomatous tissue, it is basically arising from the fat tissue, that is lipoma or liposarcoma. Smooth muscle tumor, that is leiomyoma or leiomyosarcoma. Leiomyosarcoma is a smooth muscle malignant tumor. Okay, skeletal muscle tumor, that is the skeletal muscle tumor is a rapidomyoma or rapidomyosarcoma. Fibroblastic tumor, that is nodular fasciitis, fibromatosis, fibrosarcoma. Fibrous histiocytic tumor, that is benign fibrous histiocytoma, malignant fibrous histiocytoma. Vascular origin of the tumor, it can be hemangioma or lymphangioma. The tumor's origin from uncertain origin, that is a synovial sarcoma. This is a main classification of soft tissue tumor. So coming to the characteristic of soft tissue tumor, characteristic and how clinically it appears. Usually the epithelial tumors, it appears like smooth or granular or verrucous or hyperplastic or papillomatosis. In connective tissue also some tumor it can be a papillary or verrucous, but most of the tumor it can be seen as a pedungulated. As you see as a pedungulated lesion, this pedungulated is a base is narrow than the widest part of the lesion. Here you can see the pedungulated area, and coming to the sessile lesion. The sessile lesion, it is describing the tumor of the growth, its base is the widest part of the lesion. Okay, coming to the nodular lesion. The nodular lesion is a solid and raised lesion, is greater than 5 mm in diameter, and dome-shaped lesion. Dome-shaped lesion, you can see the elevated lesion. Okay, the base and the lesion is widest part. So most of the connective tissue lesion, we can describe clinically as a pedungulated, sessile, nodular or dome-shaped. Okay. So these are the characteristic of a tumor, benign or malignant connective tissue tumor. Clinically, we have to, how we are describing is very important. When you are going to the clinics, you are going to write the case history. This description you have to write clinically, you have to describe the lesion. This is very important to know about this describing the features. Okay, coming to the benign lesion, that is the oral fibroma. So the oral fibroma, here you can see the oral fibroma of the oral tissues. Here this is basically a reactive lesion. It is a hyperplastic fibrous connective tissue. Main etiology of oral fibroma is a local trauma or irritation. Clinically, it occurs in the mouth, anywhere in the mouth. Here, it is most commonly seen in the buccal mucosa, seen in the occlusal line. Okay, the trauma from biting the cheek, it can be seen as a labial mucosa, tongue or gingiva. It is mainly a smooth surface pink nodule. It can be a sessile or pedungulated lesion. It is measuring 1.5 centimeter in diameter. It can be seen in 4th, 6th decade of the life. So coming to the histopathology of oral fibroma, As you see in the picture, this is a epithelial lining. In below the epithelium, you can see the connective tissue. In the epithelial lining, always the oral fibroma epithelium will be atrophic epithelium, and below you can see the connective tissue. Either it can be a dense or a haploid connective tissue you can see. Usually in oral mucosa will be having a loosely connected tissue. In case of this condition, oral fibroma condition, you can appreciate the dense fibrous connective tissue. So coming to the next fibrous lesion, that is the giant cell fibroma. It is also coming under a fibrous tumor. Unlike the traumatic fibroma, it is not associated with chronic irritation. This picture shows giant cell fibroma in the tongue. Okay, coming to clinical feature of giant cell fibroma, it is the asymptomatic, sessile or pedungulated lesion. It appears papillary. In this picture, you can see the mild papillary lesion in the lateral border of the tongue. It occurs in the age group of a younger age group, third decade of the life. Females are more affected than the males. Mandibular, gingiva, tongue or palate is more commonly affected. Coming to the other area of giant cell fibroma, that is retrocuspid papilla. What do you mean by retrocuspid papilla? Means it occurs on the gingival lingual part of the area, that is the mandibular cuspid area. Behind the mandibular cuspid area, you can see the two nodules. Okay, I'll go to the previous picture. See, here you can see the two nodules. It is a bilateral or typically appears as a small and pink papule. It is more commonly in children and adults. So coming to the histopathology of giant cell fibroma, here you can see the epithelium and connective tissue. Basically in cross section, you can see the well encapsulated lesion. This is a well encapsulated lesion. Here you can see the fibrous connective tissue. You can see the stratified squamous epithelium, that is a proliferated stratified squamous epithelium. In below you can see the connective tissue. Main classic feature of this giant cell fibroma, you can appreciate the star-shaped cells. Can you see the star-shaped giant fibroblast? That's why it's called giant cell fibroma. These are the giant cell fibromas. Here in high power, you can appreciate the multiple large ciliate shells that have a multinucleated fibroblast. Okay. So coming to the other fibrous lesion, that is the inflammatory fibers hyperplasia. The other name of inflammatory fibers hyperplasia, it is the epulis fissuratum, denture epulis and denture associated tumor. It is a tumor like hyperplasia. It develops in association with the flanging area, ill-fitting denture. Most of the denture patient, they will be having this kind of tumor. Okay, it mainly develops in association with the flange of ill-fitting denture. Clinically, it can be single or multifolds associated with the denture flange. It is size is less than 1 centimeter in size. It has a massive lesion that involves most of the length of the vestibule. In this picture, you can appreciate the whole length of a palate area. You can appreciate the vestibule lesion. Okay, it can be appear in middle or older age group, those who are wearing the denture patients. It is commonly seen in the female patients. The another feature of this denture epulis, that is leaf-like denture fibroma. Clinically, we can call this as a fibroepithelial polyp. Okay, it occurs on the hot palate area. Just see the picture. Here you can appreciate the hot palate. Beneath the hot palate area, you can see the maxillary denture. Beneath the maxillary denture, you can see the proliferation. It can be seen as a narrow struck. You can lift with the probe. Okay, this is a pedungulated lesion, and also you can see the striations. In margin, you can see the striation. It resembles like a leaf-like structure. That's why it's called as a leaf denture fibroma. So in histopathology of denture epulis, here you can appreciate the hyperplastic of the connective tissue. In epithelium, you can see the hyperparacharacteristic area with irregular hyperplasia with irregular red ridges, and also you can appreciate the pseudoepitheliomatous changes in the connective tissue, and you can see lot of folds and grooves within the epithelium. sometimes in more inflammatory activities. So it shows eosinophils and lymphoid follicles that will present in the connective tissue. This is the main feature of Apellis fissuratum. Okay, coming to the another fibrous lesion that is called inflammatory papillary denture papillomatosis. It's also called as a denture papillomatosis. It's a reactive lesion. It is developed beneath the denture area, in palatal area, most commonly in the palatal area. Classify this lesion as a part of a denture stomatitis. Denture stomatitis means inflammation because of the denture area. Its main pathogenesis, if you say in denture papillomatosis, because of ill-fitting denture, poor oral hygiene and candidal infection. Coming to the histopathology, here you can appreciate the numerous papillary growth that is covered by the hyperplastic stratified squamous epithelium. In advanced cases, you can see the pseudoepitheliomatous changes in the connective tissue. You can see the connective tissue islands, epithelial islands within the connective tissue doesn't have any dysplastic feature that is called as a pseudoepitheliomatous changes. Okay. So, and also you can see the chronic inflammatory cells like plasma cells, lymphocytes and all type of cells you can see. Coming to the other lesion, that is a peripheral giant cell granuloma. It is common gingival growth. It can be seen as a local irritation or trauma. Can you appreciate the lesion in the palatal area associated with the canine region? It is lesion is formed by the cells from the mononuclear phagocytic system. It has a counterpart that is called a central giant cell granuloma. So clinically, this peripheral giant cell granuloma, it can be occurs in the gingiva edentulous ridge presenting as a blue or red in color. It is commonly seen as a 2 centimeter in size, nodular or 2 centimeter in size, may or may not ulcerate. Okay, it is seen in 1 to 6th decade of the life. Mean age of this lesion is 30 to 40 years of age. So coming to the histopathology of peripheral giant cell granuloma, here you can see the epithelium. In below, you can see the normal band of connective tissue. This part is called as a normal band of connective tissue. Below the normal band of connective tissue, there are so many cells. These are the cells are called as a giant cells. These giant cells have a multiple nucleus. It is shown as an immature fibrous trauma. Here you can see lot of spindle shaped cells. Along with the spindle shaped cells, you can see the extravasated erythrocytes, that is RBCs, and multinucleated giant cells. This is the classic picture of a peripheral giant cell granuloma. This is a picture of a schematic diagram given by the Maji Jo's book, that is a practical manual. Here you can appreciate the epithelium. I told you about the normal band of connective tissue. This is the lesion that's separating the lesion from the epithelium. This area that is separating lesion from the epithelium. Here in connective tissue, you can appreciate the lot of cells. These cells called giant cells. Okay, this is the classic feature of peripheral giant cell granuloma. It has a counterpart that is central giant cell granuloma. In central giant cell granuloma, we can appreciate the bony part and bony lesion. Along with the bony lesion, you can appreciate the fibrous connective tissue and the giant cells. Okay, coming to the next lesion, that is peripheral ossifying fibroma. It is a common gingival growth. It is a reactive lesion rather than the neoplastic lesion. It is origin from the cells of the periodontium or periodontal ligament. Here you can see in peripheral ossifying fibroma, it is more commonly in the gingival area. It has a counterpart that is called as a central ossifying fibroma. Okay. And clinically, it appears as a nodule or pedungulator or sessile area, red to pink in color. Okay, clinically we can give a differential diagnosis like pyogenic granuloma, peripheral giant cell granuloma, and all the things you have you can give as a differential diagnosis. In this case, in peripheral ossifying fibroma, there is an ulceration. The ulceration is the main features. Along with the nodule lesion, it is a pink or a red in color. You can see the ulceration most commonly in the interdental papillary area. Okay, it is arising from the interdental papillary area. It is 2 centimeter in size. It's more commonly in the young adults and the age group of 20 years. So coming to the histopathology of peripheral ossifying fibroma, you can appreciate the fibrous proliferation along with a mineralized product. Either it can be a bony product or a cementum-like product. Okay, so the cementum-like product is called as a cementifying fibroma. Okay, in peripheral ossifying fibroma, you can appreciate only the epithelium. Along with the epithelium, you can see the dystrophic calcification. Okay, you can see the small, tiny like globules, these kind of tiny like globules or large mass. Okay, along with the large mass, you can appreciate the multinucleated giant cells. So this is the schematic picture of peripheral ossifying fibroma. Here you can see the overlying epithelium, and below the overlying epithelium you can see the cellular connective tissue. You can see lot of appreciate fibroblast. Along with the fibroblast, you can see the bony trabeculae. Okay, this is a classic picture of peripheral ossifying fibroma. In all the fibrous tumor, it can be surgical excision is needed, and the lesion reoccurs sometimes. The recurrences happen sometimes. So coming to the other lesion, that is lipoma. Lipoma is a benign tumor of fat, is most common mesenchymal neoplasm, is the most commonly in the head and neck. It is very rare in oral lesion. It has an uncertain pathology. Coming to the histopathology of lesion, it can be seen as, clinically it can be etiology, maybe a local trauma, or it can be seen in the tongue, floor of the mouth, lips. Okay, so it's more in older age group. It's in children's is very less. It has a male predilection. In histopathology, you can see the mature fat cells. It is well circumscribed lesion. It has a thin capsule and lobular arrangement. Here you can appreciate the lobular arrangement of the fat cells. Okay, this is a benign fat tissue lesion. There are types of lipoma. Okay, it is most common lipoma is fibrous lipoma. Fibrous lipoma, along with the fibroblastic cells, you can see the lot of lipoblast. Okay, and angiolipoma. Angiolipoma, in case of angiolipoma, it is a admixture of mature fat cells with numerous blood vessels. Along with the blood vessels, you can see mature fat cells. And spindle cell lipoma. Spindle cell lipoma, you can see a lot of spindle cell. Along with the spindle cell, you can see lot of lipomatic cells. Okay, and also you can they have a specific called myxoid lipoma. Myxoid lipoma, along with the mixed connective tissue, myxomatous connective tissue, you can see the lipomatous changes. And pleomorphic lipoma, as like a pleomorphic adenoma, what we see in the salivary gland tumor, you can appreciate the mixed kind of cells like bone, chondroid, and other kind of cells. Along with the mixed kind of cells, you can see the lipomatous changes. Okay, intramuscular lipoma, it is mainly associated with the muscle lesion. Along with the intramuscular area, you can see the lipomatous changes. These are the different types of lipomas. There are malignant part of this lesion, that is malignant liposarcoma. In malignant liposarcoma, here you can see the malignant spindle shaped cells or univaculated adipocytes and lipoblasts cells, is small lipoblasts cells. It has some malignant features. This is called as a liposarcoma. This is a malignant counterpart of a fat cells lesion. Coming to the next lesion, what I am going to talk about is nerve tissue tumor. Before starting to the nerve tissue, I just want to recollect the anatomy of the nerve. This is the anatomy of the nerve. Here the outer layer is a epineurium. Epineurium is surrounded by the entire nerve that provides the nutrition to the nerve. Okay, coming to the perineurium, that is surround the group of nerve fibers. This is the epineurium, and inside you can see the endoneurium. Endoneurium is the surround each nerve fibers. It is each nerve fibers that is surrounded by the endoneurium. This is a basic anatomy of the nerve tissue. So now move on to the pathology of a nerve. So the pathology of a nerve tissue tumor, it is a benign nerve tissue tumor, that is a traumatic neuroma. Traumatic neuroma, it is a reactive proliferation of a nerve It is mainly from the amputation of neuroma. It can be from the trauma or tooth extraction or proliferation of the Schwann cells. It can be seen as a smooth surfaced. Okay, it is non-ulcerated lesion. In this picture, you can appreciate the lip. There is a nodule that's seen in the upper lip. There is a smooth surface nodule. So mainly because of the irritation or trauma. Okay. In histopathology, you can appreciate the hepatocyte proliferation of mature cells and densely collagenous, and you can see the myxomatosis in nature. Here you can see the group of nerve cells. You can see the multiple nerve proliferation here and there. You can see the multiple proliferation, and along with the proliferation you have a mild chronic inflammatory cells infiltrate, you can appreciate. Coming to the next benign neural tumor, that is palisaded encapsulated neuroma. That is a solitary circumscribed neuroma. It mainly seen in the nose and cheek, 5th and 6th decade of the life. It is mainly dome-shaped nodule. It is a hot palate or maxillary labial mucosa. It is more commonly affected. Palisaded lesion, in gross examination, it can be well encapsulated and lobulated appearance. Here you can see the consists of well encapsulated lesion, and in connective tissue we can see the interlacing fascicles of spindle shaped cells that have a wavy nucleus. It kind of wavy nucleus you can see. This is called as the Antony A kind of cells. It has a verrucae bodies. Verrucae body in the sense there is a eosinophilic non-cellular area that is called as a verrucae body. Further lesion I will be describing about this verrucae bodies. Okay. In immunohistochemical examination it shows S100 positivity. Coming to the neurofibroma, it is a benign nerve tumor. It is originate from the nerve sheath. Okay, it is mainly from the Schwann cells or perineural fibroblast. It's mainly from the neuroectodermal origin. That is syndrome associated with the neurofibroma is called as a neurofibromatosis. In clinically, it has a solitary lesion. Here you can see the multiple solitary lesion in the face. It's more commonly in the head and neck. In oral cavity, it's very rare. It is a slow growing lesion. It is soft and painless lesion. A size from small nodule to large mass. Okay. So most commonly in the skin, and in oral lesion it's very rare. If it occurs in the tongue and buccal mucosa, and also it has an intrabony lesion. Okay. So in histopathology you can appreciate the well circumscribed areas that is arising from the epineurium, and you have a interlacing bundles of spindle shaped cells that shows a wavy nucleus. Can you see the wavy nucleus? It like comma is a wavy nucleus. A main classic feature of neurofibroma, and along with this spindle shaped wavy nucleus you can see the numerous mast cells. This is the main classic feature of neurofibroma. In immunohistochemical analysis, as S100 positivity, it shows a focal positivity, S100 for low focal positivity in neurofibroma. So coming to the schwannoma or neurilemoma. Schwannoma is also called as a neurilemoma. It is a benign neoplasm. It is mainly originate from the Schwann cells. It is uncommon in the oral cavity. Tongue is more commonly affected size. It is associated with a syndrome that is called neurofibromatosis type 2. Neurofibroma that is associated with the neurofibromatosis type 1. This schwannoma that is associated with the neurofibromatosis type 2. Coming to the clinical appearance of neurofibroma, it is a solitary, slow growing lesion. It is an encapsulated lesion. As you see in the picture, it is an encapsulated lesion. It is arising from the association with the nerve trunk. It is from the few millimeter to several centimeter. It's like bigger in size. It also have a intrabony lesion mainly seen in mandibular area. Coming to the histopathology of schwannoma, it is the encapsulated tumor. it has two types of cells, that is antennae A and antennae B. Okay, we'll see what is antennae A. The antennae A, this area is called as the antennae A. This area, it is, you can appreciate the streaming fascicle of spindle shaped cells. These are the cells called Schwann cells. Okay, the cells of from the palisaded arrangement around the cellular area. Okay, in center you can see the acellular area. This area, this is acellular area. The pink eosinophilic area, this area is called as a Verrucke body. Here you can appreciate the palisading arrangement. In between the palisading arrangement, you can see the eosinophilic area. It is a non-cellular eosinophilic area. This area is called as a Verrucke bodies. It is mainly consists of a reduplication of a basement membrane and the cytoplasm. Coming to the antennae B cells. These are antennae B cells. There are two group of cells, that is antennae A and antennae B. The antennae B cells, it is a less organized comparatively to the antennae A. You can see the spindle shaped cells randomly arranged within the loose and myxomatous stroma. This area you can see the densely arranged connective tissue with the spindle shaped cells. Here you can see the loosely arranged connective tissue. Okay, so this is the difference between the antennae A and antennae B. In this features you can appreciate the neurilemma. You can see the antennae A and antennae B type of cells. So we can diagnose with this. So in immunohistochemical analysis of schwannoma, the S100 is a diffused positivity. Coming to the malignant schwannoma, is a malignant counterpart of the schwannoma. In malignant schwannoma, it is also called as a malignant peripheral nerve sheath tumor, neurofibrosarcoma or neurogenic sarcoma. It is more commonly in the proximities portion, especially in the extremities or trunk. It is very rare in head and neck tumor. It is main commonly in young adults. Okay, coming to the malignant counterpart, it can be affect the central area, either it can be intrabony lesion. In intrabony lesion, if you see the radiological features, you can reveal the widening of the mandibular canal, mandibular foramen area with or without irregular destruction of a surrounding bone. Okay, the surrounding bone will be affected. Here you can you can see the malignant schwannoma with ulceration in the center. This is a histopathology of malignant schwannoma. Here you can appreciate the same spindle shaped cells. It has a bizarre appearance. Okay, all the malignant features will be seen. It can be a wavy, but it looks bizarre in shape. Okay, you can appreciate antennae A and antennae B kind of cells and with all malignant features. So the neurofibromatosis, the syndrome associated with the neuroma and schwannoma is called as a neurofibromatosis. The other name of neurofibromatosis is a Band-Ringelson's disease of the skin. It is an autosomal dominant. It has two types. I already told you the type 1 of neurofibromatosis, that is associated with neurofibroma, type 2 of neurofibromatosis that is associated with schwannoma. So the neurofibromatosis type 1, that is a gene mutation of a tumor suppressor gene that is coding the neurofibromin that on chromosome number 17q11.2. Okay, the neurofibromatosis is type 2, that is the neurofibromatosis type 2 that is associated with the schwannoma, gene mutation of tumor suppressor gene that is coding the schwannomin on a chromosome number 22q12.1. Here the patient, you can see the multiple neuroma in the head and neck. So what is the diagnostic criteria for this neurofibromatosis syndrome? Patient will having a multiple neuroma that can occur anywhere in the body, but is more than 5 lesion can be occurs head and neck or oral neurofibroma. And also you can appreciate the presence of cafe au lait spots, that is a coffee with milk appearance, the pigmentation on the skin. Here you can see the coffee milk with appearance, and these are the spots are smooth and edged, yellowish to dark in color, or brown macules that varying diameter from 1 to 2 mm in size. Okay, coming to the other features of neurofibromatosis, that is axillary fricklings. The axillary fricklings is called as a ground signs. Here you can see the axillary frickling in lich nodules. Lich nodules, it is a translucent brown pigmentation in the iris. The patient will have a iris pigmentation in iris. Within the iris you can see the multiple pigmentation, brown color pigmentation on the iris. This is a classic picture of lich nodules. And other associated abnormality like CNS tumors or macrocephaly and mental deficiency, short nature, scoliosis. Scoliosis is a curvature of the spine. So this is a picture that shows what are the diagnostic criteria for the neurofibromatosis. If the patient will have a lich nodules or axillary frickling or neurofibromatosis, either it is seen in the lumps of the skin or lump under the skin, it can be considered as a neurofibroma. And cafe LA spots, already tell you the cafe LA spots is a coffee like milk, coffee with milk appearance, black and white appearance on the skin. This is the classic feature that we, along with this, we can identify as a neurofibroma. Coming to the diagnostic criteria, already I told you, along with the picture, you can see 6 or more cafe LA spots macule and 2 or more neurofibromatosis and frickling in the axillary area, optic glioma or 2 or more lich nodules and osseous lesion like osteoma and other lesion associated with this condition, you can call this as a neurofibroma. And also you have to ask for the patient history, whether the patient have a first degree relative like a parent or sibling that's having a same kind of symptoms and same kind of disease like neurofibromatosis, I have to ask. End of the session, I want to complete this session with a fibrous lesion. Here I have discussed about all the fibrous lesion. Along with the fibrous lesion, I told about the lipomatous lesion and nerve lesions. So these are the very important for diagnosing the soft tissue lesion. Okay, the benign soft tissue lesion is very important. As we see clinically by the patient in our clinics, we have to identify, so we have to familiar about this topic is very important. It has a vital role of diagnosing this tumor. Okay, so whatever picture I've showed is from the Schaeffer's and the Neville. Kindly please go through the books before reading the chapter. Okay, go through the pictures. Okay, thank you all.